Thank you for kind introduction, and I really appreciate Dr. Patel for kind invitation every time, right? So I try to focus on, especially in case with complex PCI, right? This is my disclosure slide. So there are many complex lesion treatment, especially the diffuse long and severe calcification, bifurcation, etc., and acute coronary syndrome sometimes. But in case with CT or OCT never work very well, right? IVAS is the best to see. So how to use an OCT? We always followed this algorithm, OCT-guided PCI, LLD max, 2 pullbacks originally, but sometimes 3 or 4 pullback, because between the procedure we try to measure or check the result, right? What is M? M is morphology, as Samir said in IVAS, and also the length, and also the diameter. It's completely same, right? And after putting a stent, we try to check the medial dissection, M, and apposition and expansion. All are very similar to IVAS, right? And I'm very lucky to cut this portion because Samir already explained in detail, right? So let's move on the diffuse long complex lesion. This is an LAD lesion, very diffuse lesion, much more diffuse lesion we did in the morning today. Dr. Patel did a very wonderful procedure, right? So this is too tight to do the OCT, therefore we need to do the pre-dilatation first, right? And then after pre-dilatation, we did an OCT, an angioco-registration. You can identify this is in the distal portion and this is a proximal portion, right? And then let's move on the MLD, right? And before procedure. So what is a morphology? It is very simple compared with IVAS, right? If the fibrous plaque, you can identify signal-rich homogeneous portion, right? The calcium is like this. The signal poor, clear border, you can easily delineate. Here is a calcium, right? And the lipid, signal poor, diffuse border. Diffuse border means difficult to point out where the lipid starts, right? So it's quite easy. And this is a clinical case. Here you can identify some fibrous plaque. This is almost normal. And severe calcified, more 360 degree. And here is a spotty calcium and lipid plaque, diffuse border. We cannot see the behind this lipid, and also you can identify fibrolipidic. But the real world is a little bit complex, as shown in this slide. Within the calcium, there are some shadow or high signal. So it's sometimes macrophage and or lipid. So also this is very complex. Superficial calcium with fibrous and lipidic. This is a real world. But if you know this basic identification, maybe 90 to 95% perfect, right? So accuracy is very good. And then let's back to the case, right? Distal portion, you can identify there's some calcium and lipid, and here lots of calcium, right? So we can identify the lots of calcium. However, all the calcium is less than 90 degrees, so we can we don't need to do the ablation or the IVL in this case. Just putting a stent, we can dilate clearly, right? And distal portion, the diameter is around 2, and proximal and 2.5. This is an LED, so we need much bigger in the proximal side and a little bit bigger, because this is around 48. So how to decide? Based on the lumen, we cannot see the ML EL to EL, so we cannot identify the distal or the vessel area. Therefore, we decide the stent size based on the lumen, so quarter size bigger, so at least 2.5, right? And in the proximal, at least 2.75, but the proximal LED, we want to have 3, right? Then, so as I told you, the distal is 2.0 and proximal 2.5. So we decided the stent size, as I already explained. The length is 48. Now we have a 50 long stent, but at this time we do not have 50. Therefore, we decided 2 stent strategy, right? So distal part and proximal side. So if the distal is 2.25, mid portion should be a 2.5, right? Therefore, we selected the 2.5 and proximal is 2.75 because we can dilate the to 3 up to 3 because of the post dilatation. How about the length? Compared with IVUS and OCT, there are good correlation, the real measurements. So the length is completely correct as shown in this slide. And also, this already explained the Samir, right? As I told you, if you use the lumen-based approach, stent size should be a quarter size bigger, and the EEL vessel area, the quarter size smaller, and then point is the distal landing zone should be a plaque burden less than 50%. And OCT, as I told you, it's quite easy to identify the lipid, so no lipidic is the important, because if the distal landing zone is lipidic like this stenosis, edge stenosis significantly higher than the other tissue, fibrous or fibrocalcific and normal, right? Therefore, try to avoid the lipidic portion as a landing zone, right? And then, as I told you, 2.5, 26 and 2.75, 26. And this is the result after putting a stent. Here is the stent edge, and here the proximal edge. And the distal portion is 2 to 5 in diameter, and proximal is 2.9 in diameter, and the length is nearly 46 or 7, right? And so you can check the position and the size. And if you try to decide the distal proximal reference here and distal reference here, the under expansion can be identified in this portion, but too long and the mid portion or just after the big branch, diagonal branch, the reference, proximal reference should be different, right? And MSA should be 4.5 square millimeter by OCT and more than 80%, as Samir said, and the malposition should be less than 400 micron, and the edge dissection try to check as shown in this slide. And as I told you, if there are big branch, vessel size yes, may different compared with the proximal site, and if we use this technique, we can get a good correlation between physiology and intracoronary imaging. Then we move to the case. The mid portion is nearly 2.75 meter, right? And this portion should be area stenosis is 26 and diameter stenosis 13. It should be okay because the opposite side of the normal portion of the MLA site, big calcium and completely normal the opposite side. If we dilate here, may have the risk of the rupture. Therefore, we have to accept. Then the MLD max. I just talked about the post-stenting. Medial dissection, no dissection, opposition is okay, expansion is okay in this case. And this is angiographically result, looks good. And then, so why we use the OCT? Because OCT may change angiographically complex lesion to relatively simple, right? Sometimes looks in a very diffuse long region, but very easy to treat based on the imaging. Today also, the last case, I speculate lots of calcium and difficult to treat, but only spotty calcium and fibrous. So it's quite easy to put a stent. So relatively simple, right? So let's move on to severe calcification. This is a case 60 years old, and hypertension, dyslipidemia, and diabetes. And then Yeah, lesion is a little bit simple, the mid portion, yeah, right? But you can identify the calcium, here spotty calcium, here by fluoro, and also here is calcium, right? And OCT demonstrate very thick eccentric calcium, more than 1 millimeter, right? And the opposite side, you can identify the diagonal. If you put a stent simply, the carina shifts to the diagonal side and may pinch the diagonal branch. Therefore, we did an orbital atherectomy. You can identify some ablation using a low speed. Then we move to the high speed, and we succeed to make the good ablation. Then we did because the thickness of the calcium becomes less than 500 micron, and then we dilate and make a crack here, and then put a stent, and the final result is very wonderful without any kissing balloon technique, right? So this is another case, colon cancer. She had a chest pain before the operation. The surgeon referred to us to check. And here is a stenotic site. Any device could not pass this portion. Therefore, we did an rotablator. This is a Terumo OCT, right? So the black and white. And circular calcium can be identified. The lumen size is not enough by the after 1.5 millimeter bar. Then we did a 2 millimeter bar, and here is the final result. Still some calcium, but the lumen size is acceptable, and the patient have to have the surgery. Therefore, we avoid to put a stent. We did a drug-coated balloon, and patient did the very wonderful prognosis after colon cancer operation. But if you try to want to put a stent, it is very important to make a crack dissection here as shown in this slide. And if the thickness is less than 500 micron, you can make a crack and put a stent. You can get a good expansion as shown in this slide. And as you may know, if you make a calcium crack, fracture, the minimum stent area is bigger, and stent expansion is better, and the binary distance is less, and TRR is less. So it is very important to make a crack before you put a stent by high pressure ballooning or cutting balloon or something, right? And there are also similar to IVAS, we have the scoring system by using OCT based on the calcium angle, thickness, and length. Angle is put up 2 point if the, more than 180 degree and 500 micron in thickness and 5 millimeter in length. And if the score is more than 3, you try to do the modification by ablation or something, right? And this is IVL result. My colleagues summarize their experience. Yes, if there are superficial calcium, here is the result, and absence of the nodular calcification, and thickness is less than 500 micron and more than nearly 108 degree, you can get a good fracture, right? So nodular calcification is still the problem based on this data. And also this is an IVL result. Yes, upper side is the eccentric calcium, lower side is concentric calcium. In a case with the circular calcium, after IVL you can make a crack as shown in this slide. However, very thick calcium in the eccentric type is sometimes difficult to make a crack, even we use an IVL as shown in this slide. Making a crack by OCT conformation similar to the high pressure ballooning as shown in this slide, nearly 180 degree and nearly 500 micron. Compared with IVL and high pressure ballooning, very similar result, but then IVL should be a little bit better compared with high pressure ballooning as shown in this slide. So there are some recommendations. Balloon crossability is very important. If balloon cross, you can use the imaging, right, and check the calcium score from 0 to 4, and if it is the less than 3, you can use a non-compressed balloon or cutting balloon, right? And also, if it is 3 or 4, you need some lesion preparation by using ablation. And if a balloon is not crossed, it is important to do the modification to pass the imaging, right? And then try to do the imaging, and then finally, it is very important to identify the optimal balloon expansion. You can see that using IVL, you can suddenly identify the balloon opening when it is very effective, right? And then if you get enough lumen area, you can put the stent. But if by a simple high pressure non-component balloon or cutting balloon, if it is not enough expanded, you try to do the IVL as shown in this slide. And recently, this is an Abbott new OCT. It is easy to identify the calcium angle and the position of the calcium as shown in this slide. This is very convenient for the beginner to identify the calcium and distribution. And the still problem is a calcified nodule. We have to differentiate nodular calcification and calcified nodule. We discussed a lot during this 2 days discussion. Calcified nodule, it looks like a calcium, nodular calcium, but you can identify the shadow because of the mixture of the thrombus and calcium. Right, so the looks like a little bit different, right? But the prognosis is very poor because, as I told you, if there are lots of protrusion at the site of the stent, this stenosis rate is significantly high. So at the moment, we do not have any good solution, but in the near future, yes, we will have. But so I would like to say, in case with severe calcification, it should be very important to assess thickness distribution of the calcium 3-dimensionally, and with the information of the distance between guide wire or imaging fiber and the calcium for planning lesion modification by orbital atherectomy or rotablator to obtain the ideal or stent expansion, position and symmetricity in case with severe calcification for improving the prognosis. Confirmation of the multiple calcium plate fracture should be essential before stenting, right? And finally, I just move on in the bifurcation. So we can now confirm the cell condition and the position of the wire as shown in this slide by 3D reconstruction, and 2D demonstrate also the position of the wire very clearly. So if you select the ideal cell, you can do the kissing balloon if you want. And this is one of the case after putting a stent from distal to proximal LED, we missed, there are red color demonstrating incomplete apposition. What really happened here, right? No dissection in the distal portion. Apposition is okay in the, from here to the distal portion, but right. Okay, this is the result. Here is an malposition at the site of the bifurcation, right? So you can identify the red color. Then we did the pot, and then we can identify the ideal distal cell condition. Then it's quite easy to select the distal cell blind way, right? And then we did an KBT, and this cell attached to the proximal site of the side branch, and we could get a good orifice area. And the final result is this, right? Stent expansion is 83%. You can identify red color that demonstrate the branch, and proximal site is attached very well. And there are some recommendations which cell we have to select as shown in this slide. So there are blind way we can select this ideal cell nearly 50% or 60%. But if you missed, you try to use the dual lumen catheter, and then if you select the different cell through the other lumen, and if you try to push in, and if it is difficult, the wire is the different cell, so you may succeed. But if it is easy to push in the same, that it means the wire is the same cell, right? So crusade or double lumen catheter is effective in this case, right? Wire in the different cell. This is one of the example. If you could select the distal cell and did the KBT, right, optimal result can be identified. But if you have an link here, and even if you succeed to select the distal cell after kissing balloon, you can identify the deformity of the stent strut, and this is the worst condition, right? The main vessel cell condition is destroyed by kissing balloon technique. So if you identify the link at the orifice of the side branch, leave it alone because the result is worse, right? But it is very useful to do the kissing balloon. You can decide to do the kissing balloon, right? As I already explained. And this is a Japanese registry. A blind way we can succeed to the 50% in the distal ideal cell, but if there are link-free, if you use the double lumen catheter, 70% you can succeed to select. However, link connecting type, it might be very difficult to get an ideal cell and leave it alone. Do not do the kissing balloon. Sometimes you leave it alone. OCT may provide stent cell strut and link condition in addition to guide wire position at bifurcation site precisely by 3D reconstruction and position and expansion indicator, etc., and may improve the result of the bifurcation lesion treatment. That is my finished. Thank you very much for your kind attention.